Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
And we're back with The View on GU live from CUA. I'm Chris Wallis, joined with my co-host Ali Khan Lalani and our guest Andrew Loblaw, and building on our prior conversation, really anchored in the primary treatment question. Now we want to move into what we do down the line. And so, the great savor of the urologic oncologist is the radiation oncologist who's willing to give some post-op therapy when our surgery fails. And so, we've obviously seen an evolution of the role of post-op radiotherapy. The old Walsh data where we didn't do anything until we started ADT when there's clinical metastases, and we've slowly migrated earlier and earlier. We swung as far as having adjuvant therapy as our backbone, maybe 10, 15 years ago, really well entrenched in guidelines. But in the context, not necessarily in practice, but in guidelines, but in the context of modern practice, how do you see the role of post-op radiotherapy? Are there any patients, Drew, you think need adjuvant therapy straight out of their OR today? Or are you waiting for an early salvage setting?
So my approach and my read of the literature is that really nobody needs pure adjuvant therapy. I think there are a bunch of patients that we all worry about that are high risk for failure, and we want to jump on them early, but I actually don't see any downside with watching the PSA closely. And if you look at there's 3 randomized control trials, and I think one of them that was the best was the Radical study. It was 3 consecutive rises or 2 rises with a PSA above 0.1. The chance that you're going to cure a patient adjuvantly but not at 0.1, I think is 0. And that's my sense until we get the data. And, I think it's important to recognize, and I think we all understand this and recognize it, but radiotherapy has side effects. Not awful side effects, but some patients have a lot of side effects. They're really bad side effects, right? So hemorrhagic cystitis, sometimes requiring admission and transfusion and things like that. And if in an adjuvant setting, a third of patients didn't need that post-op therapy, you're really putting that patient at risk and you're not helping him. So my own personal philosophy, and I think if you look around and talk to the thought leaders around the world, like Chris Parker, we're all moving to early salvage. And I was kind of snickering because you're like, well, the guidelines say we should do adjuvant, but no one actually did. Like if you actually look at the practice patterns at RWEs, it was like 5 to 10% of people actually gave it. Then the question becomes, there's a couple of questions that come around of that. Now, one of them is that going back to this hypofractionation question. So we used to give 33 treatments of radiotherapy, sometimes more. There was a push towards, should we escalate the dose? Take-home message, doesn't help. Adds toxicity, doesn't actually improve outcomes. So we can walk away from that one at this stage. Then the question is, can we get away with radiotherapy given in a shorter duration? In the Radical study, they allowed patients to have 20 or 33 treatments. The oncologic outcomes were exactly the same. And in fact, 20 treatments was tolerated a little bit better, and it's better for patients and it's better for the healthcare system. So we've moved to 20 fractions. Another question that comes up is, what's the volume of tissue that we need to irradiate? What's the volume at risk? There are several trials. One of them, the big one, is the NRG, I think it's 0516 or something study. So they looked at post-op radiotherapy to the bed, post-op radiotherapy with hormones, or post-op radiotherapy to the bed and the pelvis and hormones. And essentially that study showed a progression-free survival advantage for patients who got the whole pelvis and ADT. And it seemed to benefit patients who had a PSA above a certain PSA threshold. And 0.34 was the one that came out of it. But essentially higher PSAs, we want to increase the volume of tissue. When we're doing surgery, Chris, I don't know how many nodes you normally take out, but some of your colleagues, 3 or 4 would be an adequate dissection. Like, I don't know what you aim for, but
I think node count is one of those highly variable outcomes. whether there's a surgeon
margin status.
No, there's a surgeon. Well, I guess there's a surgeon component and there's a pathologist component, right? The same packet of tissue on someone else's table. I mean, I think most of us try and get like 10 or more. But
sometimes the pathologist can't find it. I'm not blaming pathologists. Anyway, so what we're saying is that, there's like probably hundreds of lymph nodes in the pelvis, right? And if you're taking it 10 or 12 or 15, then, there's still nodes at risk. Mm-hmm. And so higher PSAs have been shown in randomized data to improve outcomes. ADT improves outcomes. I typically use a nomogram. I use the 10 Duclar nomogram. So you plug in the patient's specific information, and it says at 10 years, this is your chance of being disease-free. If you add in hormones, this is your chance of being disease-free. And I say, and it's 6 months of hormones. And I talked to them about the pros and cons. Then what came out was the other part of the radical study, the hormone duration part. And that's really muddied the water, I have to say.
Very hard to interpret data, so at least for a urologist.
Yeah, it's hard for us too. So what I showed is that 24 months of hormone therapy had a progression in overall survival advantage versus shorter durations like 6 or 0. And 6 had really no difference versus 0. The problem is when you start to dig down into the longer duration hormone therapy versus shorter duration hormone therapy, if you look at their overall hormone treatment duration, it's really no different between the arms. And so then we're like, you're just shifting, you're just pushing off, or you're giving treatment up front that you would have normally just given later without really any benefit. So I think more is stay tuned. I think that's kind of my message on this. There's an individual patient data meta-analysis called DADSTOP. So they're going to look at radicals, HD, and the GTUG, and there's another study I'm blanking on right now, but they're going to put it together like the artistic meta-analysis. And so I look forward to that, and I'm hoping, I hear, that they're going to do a subset analysis to figure out which patients benefit more from longer-term ADT. And I don't know if we want to get into genomics, but that's the other potential. So there are tests that we can do that stratify the patient's risk in terms of recurrence. And it's like, for example, the Decipher test seems to have the most data behind it. There's a couple of other tests as well, but Decipher seems to have the most data behind it, suggesting that if you have a high risk of recurrence, then adding higher or longer duration ADT seems to improve outcomes. There's now AI-driven pathology readouts that Artera is one of them. It's not in Canada right now, but it's actually FDA approved. And so I think we're going to see a real sea change in terms of personalized approaches to therapy, and I welcome that. So I think it's great because hormones do have a lot of important and I won't say they're devastating side effects, but they really do decrease that man's quality of life. And I think we need to be able to figure out
100%
where the bang is.
Absolutely. We talked about it before, and we'll talk about it again, but there's always creep for ARSIs into this space. We've seen some Formula 509 data. I don't think we're there quite yet, but certainly when we're talking systemic intensification, duration is obviously one component, but we can also, layer on multiple lines of therapy, and that's probably not yet prime time, but coming our way.
It's coming. So there's in the primary radiotherapy space, there's 2 NRG studies looking at that. So they're actually doing Decipher. It's a genome sequencing, and then if you're high risk, you get systemic intensification. If you're low risk, you actually get de-intensification or shorter duration of ADT. And I think that's going to be kind of like a paradigm shift for us in the future. So I look forward to that, but it's going to be years before that reads out. I'm not sure how I'm going to be practicing. Might be consulting at that stage.
Got it.
Absolutely. And so, this is the BCR idea. The next sort of big question, obviously, in recurrent disease is what happens when you find a spot of disease to treat? And so the notion of metastasis-directed therapy has clearly changed our treatment paradigm dramatically. And
I think that's a really great pivot point as well. Let's talk a little bit about MDT. So for our viewers and listeners, we'll use MDT in this context for metastasis-directed therapy. Let's start with even how we capture it. So let's look at a bit about PSMA PET imaging, and notwithstanding access points in different parts of the world, I think we've had a lot of data and studies. There's places in Ontario that generally have registries availability of this, but which patient, Drew, assuming it's accessible, it's local, it's so-called feasible, would you think is the best to select for the PSMA PET test first? We'll get into how we action on that, but maybe just even selecting that image. How do you think through that?
The way I kind of approach it in my practice and how I teach my fellows and residents about it is I kind of try to get them to think about how you're going to manage this patient going forward. So if there's an older guy with a slow PSA doubling time and you're going to do intermittent therapy kind of as your fallback, then I don't feel strongly about imaging that patient because maybe they're going to, have some heart disease or their diabetes is going to progress. And, that's actually what's going to cause their demise as opposed to the prostate cancer. Younger patients where I want to be aggressive and I'm thinking about either local salvage or metastasis-directed therapy, that's the person I'm going to jump on early. If they had primary radiotherapy, as soon as their PSA goes 2 points above their nadir, essentially from all intents and purposes, I just say if the PSA goes above 2, then I order a PSMA PET scan. I think it's important, at least for our listeners in Ontario, that anyone can access a PSMA PET scan in the community. Now, it doesn't have to go to those centers with the registry. It's a gallium-68 scan, but it's paid for by the government. And the wait times are very reasonable. I think they've actually normalized pretty much in the community and
generally
in our centers.
Yep.
It used to be many months, and I think it's 2 to 4 weeks now, and I think that's a reasonable wait. In terms of what I do about it, we can talk about that a little bit.
Let's do that.
So again, the approach. So let's go back. I always like to go back from an evidence point of view. So what is our standard? So the way I start the conversation with a patient is the standard of care is either intermittent androgen blockade. So if their scans are negative, conventionally, then they're not metastatic. And the standard of care in that setting is intermittent androgen blockade based on PR7, which was the We Need a Crook and Lori Klotz study. Then the question is, what is the effect of being able to identify, or what is the value of identifying patients with novel imaging that are conventionally negative? Probably it's an in-between state. So if you look at the EMBARK study, for example, if you take EMBARK patients and you do PSMA PET scans, it was a Belgian study, I think. You probably know it, Chris. About 50% of patients had metastatic disease, 85% of patients had some disease identifiable on PET scan. And so these are probably patients in the EMBARK study where systemic intensification makes sense. Obviously, ADT is the backbone of that treatment. So for my part, there's there's a really good summary this morning. So people, I don't know if they can tune in. Is CUA broadcast afterwards? Can people watch?
They should have some videos, but we can check on that.
Yeah. So there's a really good debate between Nathan Perlis and Rachel Glucksman. So if you have time, please go and check that out, because I thought they did a really balanced and good job of covering the data. But essentially, there's a bunch of phase 2 studies that looked at radiotherapy alone. Radiotherapy alone basically just pushes off the need for ADT, but it doesn't cure patients. Adding radiotherapy to ADT, this is the Chad Tang study from MD Anderson. I'm blanking on the study right now, but anyways, basically showed progression-free survival advantages for that. And then we have a couple of other phase 2 studies that we're looking at systemic intensification with MDT. So it's a question that holds a lot of promise. It's not standard of care in my mind at this stage. So I align with Nathan Perlis on this. But I think in other settings, we've seen a signal that there is a progression-free survival. I've seen patients, I think we've all seen patients where we've given, let's say they have a lymph node in their pelvis and we give them ADT and we zap the lymph node or take it out surgically. And the patient's disease-free for 5, 7, 10 years. And so there is this tail on the curve, and it seems to be about 20%. So I believe in the end of the day, when we sit here in 5 years, we're going to sit there and go, of course you're going to give PSMA PET scans and you're going to zap or do surgical removal of whatever disease you see, plus intermittent androgen blockade.
So the question then becomes in our last few minutes here is, these are, detailed conversations, that experts sometimes think about or huddle with. So let's talk about just advocating for how this conversation happens. So we have all seen and heard places where decision making for PSMA PET would come through an MCC, or after PSMA PET is done, it's reviewed at MCC and decisions are made for MDT, plus or minus, do you want to give systemic treatment? I think in the general context, we're shifting towards PSMA PET are largely not so much high volume, low volume. We're just going to say, look, there's lots of other disease elsewhere and treat it as such. So these are complex conversations. And as you say, at the patient at the middle with comorbidity. So in an ideal state, or how you're doing it at your center, how does the group get together? Where is the utility or requirement for MCC in your mind? Just to take people through that patient ergonomic flow through expertise that is needed.
Yeah, so every center probably has a different approach. If I had to guess, I can tell you how we do it at Sunnybrook, just as, and I'm not saying that's right or wrong or whatever, it's just the way we do it. So if I see a patient, let's say I treated him with brachytherapy 7 years ago and he recurs, I do a PSMA PET scan and he's got a couple of lymph nodes in the pelvis and maybe one in the back of the abdomen. If it's pretty clear, then I generally approach him, if I have a trial available, for that clinical trial. And patient may or may not decide to go on the clinical trial. I think what's a little different about Sunnybrook, and people can complain about this or tell me I'm wrong about this, but we do not allow metastasis-directed therapy to be used off of clinical trial unless it's approved by MCC. So we do allow exceptions, but it forces patients to go into a clinical trial so that we can answer those questions and actually elevate, float everyone's boat. Because I think part of the problem, if you don't prospectively collect data, you don't know if you're doing some harm and you don't know if you're doing any good, right? So I think to be arrogant isn't the right word, but to be so confident that you know what you're doing when the data doesn't support that at this stage, I think is not our personal philosophy. There are patients where you do a scan and the report is not as clear as you'd like, right? And so those are the patients we bring to MCC, or if I want to get my people, if they're done, for example, in the community, and I want my people to look at it, they know what I'm thinking, they know what I'm looking for, and they'll be able to give me fresh eyes. Plus, it gives me a sense from my other people that I'm not offering a treatment that's unreasonable for patients. That's how we approach it. Our MCC has basically become PSMA rounds. I'll just share with you. Like, it's like, we don't see renal cells. We don't see bladders at all. Like it's all prostate cancer PSMA rounds. But I think patients have done really, really well, having eyes on, if some people like the war analogy, some people don't. I like the war analogy. But so if you have eyes on the bad guys, right, then I think we have treatments that can augment and work together, complement each other. The analogy Nathan used this morning was, do you dig up the dandelions or do you spray the lawn? I think we need to do both.
Right. No, and I think that's important, that the ideal state of having everyone treated in an evolving space on trial protocols is ideal. That's the way it should be done. And we all know that there are decision makings happening ideally at MCCs, but we are sprinkling a bit of everything together. The metastasis-directed therapy, systemic therapy, how long. So these are really important conversations we won't necessarily solve today, but I think our viewer and listeners benefit from hearing about it. Because, by the way, if you start telling medical oncologists, you need to start ordering PSMA PETs because lutetium is in the water, let's say. Well, now these MCCs, which I chair at our center, I think deeply about our time limit and how much we try and keep things on pace. Well, you're reading how many more PSMA PET scans, and by the way, these multi-D bladder conversations need to happen as well. So, I think we could go on and on with you, Drew. So thanks so much for joining both of us today. My name is Ali Lalani. I've been joined by Chris Wallis and our special guest, Dr. Andrew Loblaw. Don't forget to rate, review, subscribe to The View on GU. And until next time, we'll see you then.
Thanks for having me out, guys.